All right, well, my name is Scott Goldsmith. I am a clinical fellow in hematology and oncology at the Washington University School of Medicine in St. Louis. It's certainly a privilege to be presenting to you today on a virtual stage with such giants in the field. And today what I'm going to do is I'm going to present a couple of cases in which CAR T-cell therapy was used for different clinical scenarios. And so what I'm going to do is present a skeleton, for lack of a better Halloween pun, a skeleton of the patient's treatment and disease course, and then ask some questions or some considerations to our panelists so that they can kind of flesh them out and give us a little bit of an insight into the decision-making process for patients in these situations. So the first case I'm going to present is on CAR T-cell therapy in multiply relapsed multiple myeloma. The second is going to be the introduction of CAR T-cell therapy as part of first-line therapy. So our first case is a patient who's 64 years old. He was diagnosed with IgG multiple myeloma in 2015 when he presented with numerous compression fractures. At diagnosis, he had some adverse chromosomal features and had ISS stage 3 disease at diagnosis. So this is a timeline of the patient's treatment and disease course. So he was diagnosed in 2015. He was treated initially with 3-drug therapy, but developed neuropathy. So the bortezomib had to be discontinued. He then continued on lenalidomide and dexamethasone for 2 more cycles and achieved a very good partial response. He then met us, and we took him to an autologous stem cell transplant. He was able to develop a complete remission at a time and went on lenalidomide maintenance. He tolerated that for about 3 months, but developed some toxicity and actually was taken off of it at that time and was on no maintenance therapy. About a year or so later, he started developing a rise in his M spike and was also found to have new bony lesions. So documented progression, and subsequently went on a number of other therapies. The first of which was carfilzomib and dexamethasone, but he continued to progress even after two cycles of that. He was then enrolled on a clinical trial of an immunotherapy, but did not respond to that either. Subsequently, he went on daratumumab, pomalidomide, and dexamethasone, and this he did respond to for a little bit over a year, but once again progressed, and that brought us to the spring of last year. So here was a point where we were at a point where we had to make a clinical decision as to what was next in this patient's treatment arsenal. And so first I'd like to just ask Dr. Majori, what in general are some options for patients when they have triple class refractory disease or penta-refractory disease in this particular patient?
Yeah, I mean, I think that's a good question. I mean, it's an interesting case, and this is a case that we often see in our clinics, right? Relapse refractory patients that have exposure to the 2-PI, the 2 IMiDs, and the anti-CD38. One of the things would be, I highly recommend as a clinical trial, if there could be something that they could do as a clinical trial, whether it's, I forgot the age of this patient. What
He was
was the age?
65.
Okay, yeah. So, I mean, you have clinical trials of bispecifics, you have the approved agents like selinexor and the GSK ADC that they could possibly do as well. And then you also have CAR T-cell therapies and there's also new targets in bispecifics besides just BCMA, right? So something like that.
Okay, well, thank you very much. Dr. Vij, in a patient with this type of presentation, why not repeat a stem cell transplant or work toward that?
Yeah, so again, the role of a repeat stem cell transplant is not uniformly agreed upon. I would say that we tend to do several transplants in patients who relapse, but usually tend to do them in patients who have long remissions after their first transplant, and then usually as their next line of therapy, where usually it provides about 40% to 50% of durability of the first transplant. In a patient who has multiply relapsed, if there are other options, one would exercise those because the duration of benefit of transplant after a patient has multiply relapsed is going to be much shorter. In some cases, it may be justifiable to do a transplant even in patients who have multiply relapsed. One is that it may offer patients sometimes the few months that it may offer may allow them to get onto a promising therapy that is about to be commercialized, like CAR T cells, or in some cases, when patients' blood counts are not able to be maintained to tolerate treatments, either experimental or commercialized, then doing a transplant later may actually give a boost to their counts. So I think this patient is neither at the end of the line nor just first relapse. So I'm not usually inclined when there are other options for this patient to take him to a transplant.
Thank you. And Dr. Munchie, are there any specific factors that you look for in a patient when you're considering either enrolling them in a CAR T cell therapy trial or a type of patient you would want to be referred to you for CAR T cell therapy consideration?
Yeah, so it's a really very good case selection, Scott, and it highlights all the points about patients. So one of the things I didn't see the depth of the response at various stages.
Mm-hmm.
I'm presuming he did not either get CR for sure, did not get MRD negativity, looking at the duration of response. And
it
so I think,
yeah, it wasn't checked at the time, but yeah.
Right, in 2016, 17, we still didn't do it routinely. But the point would be that I think patients like this, and whatever the risk stratification in this patient, having relapse with a very short PFS for each of the treatment does indirectly suggest functionally higher risk disease, that the patient is developing resistance very quickly. So these are the situations where getting a deep response is probably going to give us a little bit better longer term outcome, longer PFS, and for sure longer overall survival. And so I think the fact that patient has multiple treatment, the fact that his responses were not as deep as we would have liked for a good outcome, suggests that any treatment which can give us that is what we should use. And of all the options we have available, and the good news is that this patient, even without CAR-T, has multiple options, as Dr. Madhuri suggested some of the list, and one could add with on that list also have permutations and combinations. Having all those options, I think the one option we know that in this late stage, 5th, 6th line and beyond, that can give us deep response, MRD negative response is CAR-T. And I think that's why I would think that when commercially available, for sure, and even in the research setting, in a clinical trial setting, he would be a very good patient to be put on such study, and very good patient from the angle of the patient, that it is going to benefit him in getting good outcome.
Great, thank you. So, right, this was the decision point, the fork in the road that we were at, and it was whether to choose standard of care drug therapies or enroll in a drug clinical trial. He was otherwise very healthy and functional, or consider a clinical trial using a CAR T cell therapy targeting BCMA, and that is ultimately what was chosen. So, Dr. Munchie, I just was wondering, could you just speak a little bit more to the availability of CAR T cell therapy currently, and any expectations within the near future, either both on or off of clinical trial?
Perfect. So I think that's a very important question, Scott, for our patients at the moment. I think the word is out now that CAR T cell is extremely effective, very encouraging. It comes from all of us and also in general media. So because of that, there is a great need for it. But from the angle of studies and from the angle of conveying to our patients, this is still a new treatment. If you look at transplant, some of us have done more than 1,000 transplant personally, but if you collectively look at even just America, there are 20,000 and more transplants done, and that's the cumulative data we have to know how to take care of the patients, what happens, and what we do. If we look at the CAR-T experience, around 500 patients treated so far, except the results are so outstanding that we are talking about this whole special session on it because of the excitement about its efficacy. And because of all this buzz, there's great demand for it. On the other hand, it's still a new treatment. So we have phase 1 and phase 2 study, which we do not even have a very good phase 3 study data, comparative data. So this is very early stage of the treatment development, and as required by regulatory authorities, as required by the companies we use the study, and more importantly for all of us on the research side, we want to be extremely cautious. We don't want to hurt and harm the patient by doing it while we are learning it. And that's why the number of slots available for this study are very limited. Each center, normally for all the small drug studies that you mentioned, I can put patient on the study anytime because those slots are available. For CAR T cell, it's not the case. Each center would probably for each study would have one slot a month or so you can put one patient a month. And I know in our center at a given time, we have 100+ patients on a wait list to see if they can get one of these slots. Fortunately, there are more studies opening, so we have more slots. But the point is that currently these studies are being done carefully, but that also limits the number of patients we put. So we are all very eagerly waiting for early 2021 when we expect that a commercial product would become available. That's the expectation based on our experience and our hope. And we expect that a second such CAR T may also become available later in the same year. And once that is available, I think we will have a better and quicker use for it. There would still be some caveats because this is a drug that needs to be produced. The CAR T cells needs to be produced. So what is going to be the production capability of the company? It's not going to be unlimited as if we are giving somebody Revlimid or giving Velcade in a bottle. There would be some limitations to that. And number two, which Dr. Vij very, very well described, are some of the financial issues that needs to be considered, etc. So there is complexity. We want to still right now look at the bright side that it's a great option for a patient you just described. And if clinically available, I think you did what I would also do. And if commercially available, that becomes an easier option.
Thank you. That was a very fantastic answer. Dr. Midori, you covered this really nicely in your talk, and the comparisons between the different immunotherapies out there, both as standard of care now and also on other clinical trials. I was wondering, are there any factors in regard to a patient that would lead you to pursue the CAR T cell therapy on a clinical trial versus another immunotherapy, either as standard of care or on a clinical trial, likely ones targeting BCMA as well?
Yeah, I mean, I think this is a very good question, Scott. This is something that is always something that as physicians, when we're seeing these patients, we have to decide as you had the fork in your road. Are you giving them CAR T or are they good for another immunotherapy option? And as I mentioned before, there are certain factors we have to look into for the patient, right? How aggressive is the patient? How many comorbidities does the patient have? What's their age? And is age just a number? Like, is their age, but are they good performance status, right? And so when you think about it, it's maybe that right now, as Dr. Munshi mentioned, we don't have a CAR T that's commercially available. So you have a patient that's coming to you that's heavily relapsed refractory and you don't have a CAR T spot for them, right? What are you going to do? You have to give them the next best option to help tide over the time for when they can get on a CAR T. Right now, unfortunately, most of the CAR T clinical trials omit you if you've had prior BCMA, but now we're thankfully opening newer cohorts and newer arms where if you've had prior BCMA bispecific or you had the GSK ADC BCMA drug, or even as a BCMA bispecific, you can still maybe enroll in one of these trials. But at the moment, there are other bispecifics that target, the FCFR. The Genentech has a bispecific. Janssen has the GPRC5D bispecific. So sometimes if we have a young patient, but that's relapsed and we kind of want to wait for the CAR T, we try to see and we don't have a spot, then we do one of these other bispecifics and then consider putting them on the BCMA CAR T when we have that available. But I think, like I said, it just depends on the time and what's available. If you have somebody that's really elderly, has a lot of comorbidities, you can't, do a CAR T, then they'll have to do their next best option, which would be bispecifics or ADC.
Great. Yeah, I think that actually covered some of the questions that were in the question and answer, especially regarding the use of a BCMA targeting agent before being enrolled on potentially a BCMA targeting CAR T. So that's very helpful. And then Dr. Vij, could you just briefly go through the timing of CAR T again, and also I wanted to ask a little bit more specifically in regards to choosing bridging therapy. Who do you choose to bridge with some type of bridging agents? And then what would you lean toward and what do you shy away from in such patients for the bridging?
Well, that, again, as far as the manufacturing time for CAR T cells for myeloma goes, I think it's going to be 3 to 4 weeks. And so you do need to, in the meantime, in a lot of patients, give some kind of treatment to keep the disease in check. Now, on clinical trials, we're often limited by what we can do in the phase before the patients are going on to CAR T cells. However, the fact is that when we have commercial product, we'll be at lib to do what we wish to do. And in that case, I think that we will be using drugs that patients have perhaps not even seen before as a bridge to therapy to keep the disease in check, or have used before and used them in new combinations. That I think is going to be an area of evolving interest. What would we like to avoid? I think that, again, if you're giving a BCMA-directed CAR T, though we don't have data, perhaps if we are able to, then avoid another BCMA-directed product, at least in the bridging period. That's the only thing I can say.
Excellent. And then you also actually already touched on this in your talk on the idea of therapies that come after CAR T cell therapy. They're parts of clinical trials and questions that are being answered. I think there was a question in the Q&A regarding, are there any maintenance protocols currently, but that is also an area of exploration. So in the interest of time, I'll move on. But so this patient's CAR T timeline, he was enrolled on this clinical trial. About a month later, he underwent collection, bridged with IRD, had not seen Exasma before, and then went on to have a bone marrow biopsy prior to being admitted for his treatment, still had 15% plasma cells in his bone marrow, underwent the lymphodepleting chemotherapy, received the CAR T cells, and then was discharged from the hospital in only about 2 weeks. Suffered only grade 1 CRS and no neurotoxicity. Day 30 bone marrow biopsy showed 2% plasma cells. He was in an MRD negative CR even at that point. And then over a year later, still in an ongoing CR. So I think in summary, thanks to the physicians who went through some of the questions, but BCMA CAR T can provide long remissions and deep responses, even in heavily pretreated patients. It is currently available on clinical trials, which does limit its availability, but hopefully, as Dr. Munshi mentioned, there will be an approved agent soon. And it is an aggressive treatment, so you do need to consider the comorbidities and health status of the patient going into it, and then also how fast their disease is progressing due to the long manufacturing time in the process of enrollment and that sort of thing. So the second case we'll go through a little bit more quickly, but it's a 58-year-old man, IgG myeloma, diagnosed with some myeloma-defining events with 60% plasma cells and a vertebral lesion in 2018. His disease risk was standard disease risk, and so he was diagnosed, went through initial treatment with RVD only ×1, but then was switched by his physician to IRD ×4. And you'll notice that the M spike actually started to plateau. It did not really fall below this 1.3, 1.4 level, so he was stuck in a partial response. Did decide to go through autologous stem cell transplant, and the day 100 bone marrow biopsy still demonstrated the persistence of plasma cells, and the M spike really maintained at that plateau, unfortunately. So this to us was a suboptimal response, and I just wanted to ask Dr. Munshi in regard to, this might actually bring up a little bit of debate, but in regard to response to first-line therapy, what would you consider an optimal response? And then also in the context of designing a CAR T clinical trial, what would be considered a suboptimal response that you'd like to introduce CAR Ts to?
Okay, so this is really very interesting scenario that is evolving in how we manage these patients. And this again comes from, and I come back to that point again and again, is that we all are beginning to believe that getting MRD negativity is our ultimate goal. And what it does and we don't want to make it an MRD discussion right now, but what it does achieve is that it can overcome the risk factor. So if a high-risk disease patient get MRD negativity, his outcome comes closer to standard risk patient. And so what is suboptimal? That's an evolving concept. So in a traditional sense, this patient getting barely a PR after transplant is a suboptimal response. I think CR in 1.5 is CR, he is 1.4 before transplant, 1.3 after transplant. He had a very minimal effect after transplant. Now, I don't know his risk stratification, but quite often he does not need to be a high risk to have this kind of feature, as we previously talked. It's a functionally high risk patient in some ways. And so not having a good response in a young patient, I think is quite important factor to keep it in mind. This is a situation where quite often second transplant is done, although you could say it's counterintuitive due to the first transplant had no effect. What would a second transplant do? We don't do second transplant routinely at all, but that's an area where there are studies and there is some interest that there may be effect or impact. So I think that's one part of it. Number two, if say his numbers were close to VGPR or CR, is there an adequate response or not? And this is where the risk stratification comes into picture. Currently, if a patient like that who has not achieved a VGPR or a CR and is a high risk patient, this is where I would consider doing something, and he would be a good candidate for a CAR-T, as partly because a study exists. Now, if the drug is commercially available, would I put that patient through CAR-T? I do not know yet, because we don't have a good data saying that CAR-T in that setting provides us what it does. And for that, the currently ongoing study in this situation are going to be very informative. Whether are we able to get deeper response, get them into MRD negativity, and that may end up becoming our goal.
Okay, thank you. If I didn't mention it, he actually only had RASS stage 1 disease at diagnosis. He did not have adverse chromosomal features either.
And that's a very interesting scenario, Scott, that sometimes or more than few times we have all seen patients who would be something like smoldering disease, my MGUS kind of disease. They're RSS stage 1, they are stage 1 by whatever criteria you use. They were indolent disease, their responses are slower, they don't get complete response, but they could still have good PFS with good maintenance. So I think that's something we should keep in mind. These are a little bit anecdotal, maybe a little more than anecdotal. We don't have a very good study just focus on this particular question. But it would suffice to say we should still use standard criteria to consider this patient for further treatment or not.
Great, thank you. And then Dr. Vij, you mentioned this in your talk a little bit. Could you speak a little bit as to rationale of moving the CAR T cell therapy earlier in line for these such patients? And then also maybe talk a little bit about the benefit and risk balance that you might be introducing by bringing CAR T cell therapies forward in a treatment paradigm.
Yeah, so as I alluded to in my talk, I think that it makes rational sense to move CAR T cells into an earlier line of therapy, because we know that any therapy we initially introduce gets introduced into a later line of therapy, and then the trials are done and it moves into an earlier line of therapy where its benefits are better realized. So CAR T in an earlier line of therapy theoretically should provide a much longer period of response. The second thing, as I mentioned, there is a theoretical reason also in a therapy like CAR T to perhaps use it earlier, as the quality of the T cells used to generate the CAR T may also get somewhat compromised as multiple lines of therapy have been delivered.
Great, thank you. And so this patient was enrolled on a clinical trial of a BCMA targeting CAR T cell for patients who did have less than a VGPR after transplant, did not receive any therapy prior to collection, did not need any bridging therapy actually, which I think is an interesting point because the patient was actually, after a transplant. So perhaps the disease was under a little bit better control than if you were progressing. Received his lymphodepleting chemotherapy, was discharged from the hospital in about 2 weeks, suffering grade 2 cytokine release syndrome, which was self-limited, not requiring tocilizumab. Day 30 bone marrow biopsy demonstrated 1% plasma cells, but still had a detectable M spike. And this did take a little bit of time to be undetectable. Almost a year before his immunofixation was negative and the M spike was no longer detectable on SPEP. did have a bone marrow biopsy a little bit of, about a year after treatment, and finally demonstrated that he was in astringent complete remission, MRD negativity. So summaries based on what the discussants had mentioned, as well as the cases themselves. The BCMA CAR T-cell therapy may deepen suboptimal responses in first line, and there is rationale that this could potentially translate to longer remissions and longer survival. It is currently available on clinical trials. We hope that this will prove to be a valid strategic, valid treatment strategy. And the disease response may be protracted over a period of time, this is a living drug in patients, and they may continue to respond even in this patient over the course of a year. So I'd like to acknowledge our discussants, myeloma crowd, including Jenny and Greg, who I really appreciate being included on this, and you all, patients, families, caregivers. It's a privilege to be presenting to you today. Thank you.